Hello and welcome to the Fund for Investigative Journalism webinar on COVID-19 data that you can use in your reporting. I'm Clarence Page from the Chicago Tribune, but my position today on the board of FIJ is what's a lot more important. We're very happy to be able to work with the Columbia University Brown Institute for Media Innovation. You're going to be hearing from the FIJ, these FIJ grantees in this program for the next hour. The documenting COVID-19 project at Columbia University's Brown Institute has been spending close to a year reporting on the local, state, and national government's responses to the pandemic. They've broken several major stories in national and regional press, and they've created a database of all the records they've obtained for other journalists to use. And I highly recommend this database. The most important thing that I could tell you about today is the availability of this wonderful well of information for investigative journalists. Most recently, they've partnered with the COVID tracking project at the Atlantic to issue public records requests of to every state to obtain their data sharing agreements with the CDC about COVID vaccinations. They will share their work with us today, and they'll walk us through how other journalists can access and navigate their data. They're going to present their work for about 20 to 25 minutes, and then we'll open up for questions. You can ask questions at any time in the chat, and we'll get to them at the end. We're very thrilled and fortunate to have this team with us today, so I'm going to turn it over to Derek Kravitz to introduce the team and to kick off this presentation. Derek?
Yep, thanks, Clarence. I appreciate that. We have three members of our team here today, and I just want to introduce them briefly, and then we're going to walk through about 20 minutes of slides and information that can help local reporters as they're navigating FOIA and data and other information on the pandemic. So first, I have Kira Sinise. She's based in Chicago. She is a graduate of Columbia Journalism School, the Beale Center of Investigative Reporting last year. She's also just published 2 stories with the Chicago Sun-Times on medical examiner death data in Cook County that ran on the front page there this previous weekend. So we're happy to have her here. Caitlin Antonios is based in California. She is also a graduate of the Columbia Journalism School's the Beale Center program from last year. She has been working tirelessly on farm worker and other California-based stories surrounding the pandemic, specifically stories related to public health indices and metrics and other ways in which vaccines and other needed pandemic solutions are allocated to populations. And lastly, we have Mohar Chatterjee. She is with a dual degree program at Columbia, both with computer science and the journalism school. She is currently a graduate student and is working on several different projects at the moment, including some involving data in Michigan in prison settings, and some other economic data on business closures. So if there's any questions at the end of this, we're going to take some, and you can also reach us offline at an email address, info@documentingcovid19.io. So I'm going to share my screen. Give me one sec. Sorry for the pings. All right. Let me know if you can see the screen here. Okay. So just a quick overview on what documenting COVID-19 is. It's a public records repository. A lot of newsrooms around the country have these sort of hidden away in their back reading rooms. Also, government agencies have their own reading rooms, but we wanted to make something specific to the pandemic. So, and specifically public health information that we thought could be newsworthy or useful to journalists. So these record sets, even though we've published 250 on our website, we have about 250 more in a Google Drive account, and all of those are essentially kept, for other purposes, to refile new requests or to tailor future requests based off the language we used in the original filing. So these 250 cover 44 states. They've resulted in 70 investigative stories. About half of those we've done our own with partners, including the New York Times, the Washington Post, the Sun-Times I mentioned, but also smaller newsrooms around the country, the Detroit Free Press, the Midwest Center for Investigative Reporting. And we've increasingly seen this data being picked up entirely without our involvement. The Wall Street Journal did a story last week where they picked up a very small filing and some Illinois data that we hadn't looked at in months. So that's something that can be really useful for journalists as they're looking for state-specific or even local county-specific information. Our project team is made up of Columbia journalism and data science researchers. It's funded through a Magic Grant at the Brown Institute for Media Innovation. But we also got other grant funding from FIJ, of course, and the National Geographic and others. The project mission, as we mentioned, internal emails, memoranda, health metrics. This can include, the number of beds available or ICU usage in specific hospital settings. It can include emails back and forth between a health department director and maybe a mayor or a governor. It can include school district reopening plans. It encompasses a lot of different public records. And so we target based off of need of a newsroom and also, what's in the public interest. Just want to briefly describe what we do generally, and then a little bit of the impact recently. And the impact might help just if you're looking at a story and you're trying to figure out how this, wealth of data or a big long spreadsheet might impact some of your local coverage. These are some use cases. 3 of our stories have extracted classified outbreak and epidemiological data from Illinois, Kansas, and North Carolina. These were requests asking for where COVID outbreaks have happened in workplaces across that state. For various reasons, states use or cite communicable disease law, usually state statute. Sometimes they cite HIPAA or federal law in order to prevent disclosure of that type of data. But through FOIA, we found that we're able to get some of that information. And so we've partnered with local newsrooms in each of those states, in Illinois with the Midwest Center for Investigative Reporting, in Kansas with the Kansas City Star and the Wichita Eagle, in North Carolina with a consortium of investigative groups, newspapers and TV and radio stations to publish those stories. We found that collaboration works the best, and especially when we have an on-the-ground local newsroom to work with. We are based at Columbia. We have no connection into some of these communities in many cases. So we need collaboration in order to achieve that. Like I mentioned before, our process involves selecting locations and making targeted public records requests. And when I say targeted, I mean specific to an individual location and looking at the unique factors that are plaguing or facing that community. In Cook County or Chicago, for example, there's a huge amount of inequity and death in specific zip codes like Cicero and other places where we've focused a lot of our efforts recently. And so we've been able to FOIA and get medical examiner info that is not on their open public data portal. That's a way we can come in and help. We review the documents, we report out the stories we find, and then we conduct interviews and research, often with partner newsrooms. I mentioned this, but our researchers come from journalism, data science, and history departments. We consult with public health experts at Mailman and other public health departments here in New York. We work with a lot of different partners here. We found that a lot of our recent coverage has taken on sort of a new dimension with variants and community transmission and vaccines. trying to figure out what the next thing is going to be with COVID, in the sense of what communities are going to be the most impacted, disproportionately impacted. And we have a few examples of that with the CDC vaccine data. I'll actually skip this slide because we already talked about it, but I'll let Kira take it from here to talk a little bit about the data use agreements with COVID tracking, and specifically in a use case with Vietnamese populations.
Thank you. So we started working on the data use agreement project in partnership with the COVID tracking project. And for that first story, we were able to compile data and contracts from 37 states. And basically this gave us insight into what kind of information different states were, and some major cities were sharing with the federal government about who's getting the vaccine. And so most recently, we've gotten records from New Orleans that show a low vaccine uptake among the local Vietnamese population. So that's kind of a next step for our project. And our team is going to be splitting that work up again and collaborating on that to see what data, if any, might be available about how the CDC is tracking vaccine allocation among Vietnamese populations. And then we will, of course, seek comment from the CDC and from Vietnamese community groups. And then on our next slide. So what we did with our first COVID tracking collaboration was basically looked for the contracts that the CDC asked every state and territory to sign earlier in the fall. And so we sent records requests to every state and territory. Luckily, we were able to get a large majority of them within a few weeks. And so we found from that research that most states withhold names, addresses, zip codes, and dates of birth for those who are being vaccinated. But some states, 7 states, go further. They redact race and ethnicity data. So what we learned that was particularly interesting was that in some places that information is available, but is still not being shared. And then additionally, we learned that most states agreed to use a software program that the federal government said would be available, but it's still unclear when that might become available to states to use. And so that program would make it more likely to share that data securely, but it's not yet available. And then we also learned,
Sorry.
We also learned specifically California, North Dakota, Texas, and Vermont are some examples of the states that use state privacy laws as the reason for not sharing race and ethnicity information. Yeah. And then, for example, California and Texas being 2 of the high population states that are restrictive in the data they share, they don't share vaccine-related ethnicity and racial data with the federal government. And then these are the same states where we've seen other data issues with racial and ethnic disparities throughout the pandemic when it comes to testing data, death data, for example. And then in California, Latinx people make up 55% of COVID cases and 46% of COVID deaths where race or ethnicity is available. And then making up only 39% of the state population. So we can see that disproportionate percentage there. And then Texas provides race and ethnicity data for vaccines on its state health department, but still does not share that with the federal government. So that's another example of how we can see that that information is there, but it's not being shared. And then we also learned California is one of the most restrictive states in redacting personal data from records. And this is another state that actually has multiple state laws that prevent sharing that information with the federal government.
And just to piggyback off of that, we found that California and Texas are 2 states that are worth further exploration as it relates to race and ethnicity data, what's being collected and what's not being collected or shared. Texas, whereas California might collect it on the ground but not share it, Texas might not even collect it at all because of opt-in requirements for people that are getting the vaccine. There are other states like Idaho and North Dakota that don't collect it at all. And then there are other states that don't publicly post any of this information online, like Louisiana and Michigan. And those are examples of states where FOIA could be useful, where if you FOIA specific health departments, county or state, you might be able to get at race or ethnicity information that is not being shared at all at a statewide level. So as we mentioned, Montana and Texas have these opt-in requirements. Imagine you're getting a vaccine. If any of you have, you go to the vaccine distributor, you get or hospital setting, you get usually a form to fill out where they ask you for your name, your address, some other identifiers. Montana and Texas have these opt-in requirements that you have to sign a waiver in order to eventually go to that next step and provide that identifiable information. A lot of people would choose simply not to do that. So that can be a significant barrier in getting timely information about who is getting the vaccine in those states. We mentioned Idaho. Privacy experts agree that this type of information is routinely de-identified or scrubbed before they get out to the public or even shared with the CDC in the first place. So there's really not a compelling argument to be made for the ability for someone to go in and re-identify someone based off of these various things. But this is an unprecedented task. They're asking states to take antiquated computer systems and apply them to modern day issues, and then share them across the board with federal agencies that they're not used to sharing it with. So that can create a lot of log jams. By withholding this information, we found that it actually could present some blind spots in the federal government's ability to identify populations like the Vietnamese populations in several states with vaccine uptake, how much vaccine those communities are actually getting. And as a result, that can mean less vaccine doses for the most vulnerable communities, the communities that need it the most. So those are worthwhile stories to report on in those communities. When we checked the CDC's COVID data tracker last, this was probably a few weeks ago, but they were reporting just 53% of vaccination records were being shared with the federal government that include race and ethnicity data. That number has ticked up slightly higher. We found in Illinois that they've done some reverse engineering where they've added in some figures, so that's closer to 60%, but still that's a significant gap. We reached out to the CDC for comment on all of these things and for stories, and many states have agreed to use a software system that they are creating to encrypt all the health data that they're getting from states. We asked when that software would be available. They said that they have procured it, they have a contract out, they're making licenses available for free and technical assistance, but no other details on this. So this is an area that we think could be useful because a lot of states are citing this as a reason to not want to share more information with the federal government. We also found that we asked the CDC if they're going to make any other changes to requirements for race and ethnicity. We found that it really depends state by state. So that's why it's important for state and local reporters to keep pushing their county and state health departments for more information about what's going on. So when we spoke to the CDC about what this all means, the larger import, they said, obviously vaccine allocation is a big issue, but the biggest issue is spotting this reinfection or adverse reaction. even though the vaccines, and in two cases, the Moderna and Pfizer vaccines are terribly effective, 96% or higher, that means there's 4% of people that could get breakthrough reinfection. And so the fear is that for those people, spotting patterns or trends amongst those that experience breakthrough reinfection 14 days after the second dose of either of those vaccines, that those are going to be missed, that those patterns are not going to be spotted. So that's an area for further exploration for journalists, we believe. We think it's important to query who is experiencing those breakthrough reinfections. As we're seeing it in New York and New Jersey, at least locally, a lot of the people who are experiencing breakthrough reinfection are healthcare workers. And that's simply because those are the populations that are being tested for breakthrough reinfection due to variant genomic sequencing surveillance. All that's to say that these are the only people who are actually being tested on a regular basis and can be spotted for reinfection. Secondly, smaller racial groups like the one that Kira outlined, the Vietnamese population in New Orleans, in California, in Texas. Those are communities that have some low uptake of vaccine and are either due to language barrier or lack of proper messaging to those communities, or in other cases, unfamiliarity with certain healthcare settings or distrust of government agencies are not getting the vaccine. So we think that those are worth further investigating by local newsrooms. Dr. Sean Granas, he's a data scientist. He does coding, but he's also a MD over at Indiana University. He talked about the big issues in Indiana where he lives. And those issues are going to be the smaller racial groups there, including Native and Indigenous populations. He just bluntly said, without ethnicity data, the CDC will not be able to conduct broad analyses connecting different variables to one another. So connecting race and ethnicity to, say, occupation. Sometimes that can be done on the ground. A knowledgeable public health nurse knows everyone in a specific community and can link a record, a medical record from someone who got the vaccine with their full zip and address, but also where they work, if they work at a meat packing or migrant farm employer in town. But there's still gaps there that requires a public health nurse or someone actually going through and linking those records. And that's not usually shared up with the CDC. So again, another example of why those type of local on the ground reporting is useful. There is going to be a upcoming CDC study that is apparently going to help address some of these data collection issues, some guidance that they might offer to states. Whether or not those states accept that guidance is another reporting question. The 7 states that don't share the data to begin with are very useful case studies. But we also think that there are other vulnerable populations that, for various reasons, are going to be resistant to getting one of the vaccines. And we think that going forward, analyzing as much as we can about those groups, including workplace employment and frontline status, would be great. And if you'd like to collaborate with us on this project or any others, feel free to email us. Our website is documentingcovid.io. And our email is info@documentingcovid19.io. We also have all of our projects here on the left-hand rail. We have one on education, medical examiners, which includes death data, meat packing and migrant farms, but also increasingly more economy and algorithmic data. So from here, we're happy to answer any questions anyone might have, and Kira will handle any of the Midwest questions, and Caitlin any of the West Coast, and we'll go from there. So I see one question in the chat. Mohar, do you want to take that one?
Oh, I was just raising an additional point about zip code data in California. For their data use agreement with the CDC, they have an interesting line that says zip codes will not be provided for anyone who is a resident of a county that has less than, I believe, 20,000 residents. Their arguments are, I imagine, are essentially you don't want to provide information that's too identifying. But the sort of the con of that is it can be really hard to track vaccine rollout in remote regions and in places where there aren't that many residents. So
Yeah. And that brings up a good point. Caitlin, you dealt with CDPH on this specific question related to when they were going to release stuff on their dashboard, and you were on the ready when they did. Can you speak to the issues you saw with the CDPH dashboard data and the discrepancies between what they have and what they're actually showing?
Yeah, it was a Friday night news dump when they posted it, which is always frustrating. And it was in percentages, which is also frustrating. And it was posted without much explanation or any sort of reference to how that data has been collected. And I mean, I think Mohar said it best. The problem with not including zip codes is that, you know, California is a very, very big state. And of course, there are certain counties that have lots of people, but there's also a lot of very big counties that are geographically spread out with very little residents. And those have been the most challenging in California to reach for vaccine dosage. And that's been a problem from the very beginning with California. So yeah, I mean, there, in terms of speaking with CDPH, there was like almost no communication back from them, despite multiple follow-ups, despite calls. They really weren't saying anything until they just said, okay, it's ready. And then what they provided, like I said, was not a very helpful set of data to actually answer the questions that we were looking for.
There's one question in the chat from North Carolina. We have gotten a bit of information from North Carolina, but we haven't gotten, I believe, the full contract yet. That's still being FOIA'd. Kira, do you know how many states we have yet to get contracts back from?
I think it's about 5 or so.
Okay, so that's worth thinking about, the states that, you know, 5 in the country. And we also got some from the territories as well. The 5 states that for some reason or another are not providing FOIA in a timely fashion. We also found with North Carolina that they are slow to provide information, but counties are more responsive as it relates to vaccine information obtained at the county level, especially in agricultural regions. So if that helps at all, but happy to talk offline if you need additional assistance. Looks like there's another question regarding COVID data in Native Americans. Are sovereign tribal nations healthcare systems collecting vaccination data, and are they willing to report the statistics? Yes and no. So I can answer this from the perspective of Navajo Nation, which we dealt with very early on in the process, and then a little bit more recently with vaccine. Navajo Nation covers multiple states, including New Mexico and Arizona. In trying to obtain information from New Mexico and Arizona, some of those tribal nations report out to county health departments. They usually report things like full number of doses administered, but they don't report things like full sort of gender and age breakdowns for everyone who's administered a vaccine dose. They are supposed to report that up to the CDC. So just because a state or a county agency doesn't get the full record doesn't mean the CDC doesn't. So in theory, that information is being collected. Whether or not that is something that can be obtained in a timely fashion on news deadline is a completely different question. But I think it's worth exploring, especially with the disproportionate impact on those groups. Kira, I know you worked a little bit with tribal groups early on. Did you have anything else to add on that one?
I don't really think I have anything else to add, but I would just agree that we've had some interaction with some of those departments, but I don't think we've gotten a large batch of information yet.
Yeah, especially there's going to be a delay, especially with some of those counties.
There's also a line in a lot of the DUAs that talk about essentially, if we're in terms of data access and use, they have a line that talks about supplying covered data from official federal, state, local, tribal, and territorial government agencies up to the CDC.
Correct.
So it's codified in the state DUAs, but there's nothing much beyond that.
Yeah, and does that mean, like, if you're a reporter on deadline, you're trying to answer those questions, does that mean you'll be able to get that information? That's a hard question to answer. In many cases, but we've had good success, if it helps, with places like Pima and Yuma, Arizona, and several of the hardest hit areas of New Mexico. So I would explore those areas if you're looking for more information. Mohar, did you want to answer this question about the vulnerability index?
The only reason I spent my whole morning actually looking at social vulnerability indices, and what I can say is. Well,
and before you do, you just want to read out the question just in case.
Oh, sure.
The
person who asked the question, Leonida, correct me if I'm wrong on the pronunciation, heard the term vulnerability index and how there was discussion about allowing race to be a factor in vaccine distribution. If Black people and other groups are disproportionately getting and dying of COVID-19, why not be first in line to get the shot? Was there ever a plan to shake up vaccine distribution? So here's what I'm seeing happening. So we currently have a lot of FOIA'd emails for essentially regarding the vaccine, regarding variants. And I saw, at least in Michigan, in a lot of the vaccine orders for the Moderna and the Pfizer vaccines, they attach a long list, which is essentially the social vulnerability index markings by census tract. So what they do is they rank the top most vulnerable zip codes in each county in that state, and that's attached to the vaccine order forms. That said, I haven't really seen a lot of communication talking about how they're using these SVI numbers that they already have in determining the number of vaccines that get ordered. So it's not really a race-based breakdown in their discussion as far as I can see, but they do have the information and it's officially part of their decision-making pipeline.
And that brings up another very difficult, probably too long to answer question that I think Caitlin could briefly describe about public health index in California. You just want to describe what PHI is and what that means?
Sure. So California created this Healthy Places Index, which is an algorithm that combines 25 factors such as housing, transportation, education level, and it essentially takes information from the census and gives it an index score. And Governor Newsom recently announced a few weeks ago that 40% of California's vaccine supply would be going to 400 zip codes that were based off of this Healthy Places Index that received some of the lowest scores. There's a bit of issues with that index. Because it's supposed to be used for more things, California has a rule about public resources aren't allowed to be allocated specifically due to race, sex, ethnicity. So because they want the index to be used for more than one thing, race is not actually a factor in the index score. But when you go onto the index and start searching through different zip codes, you can see that race and ethnicity data is included. It's just not factored into the score. So there's been still some concern that even though they're using this Healthy Places Index to determine where 40% of California's vaccine supply goes in an effort to be more equitable, there's been some discussion about various groups. Native Pacific Islanders have had some concern because geographically they're very spread out across the state, and therefore don't always fall into the zip codes that are qualifying for this 40% reserve. So yeah, that's a very brief explanation of HPI.
There's a pretty good long question here. I'll try to read it out and then see who can answer. How do you advise that reporters handle the giant share of missing race, ethnicity information in various COVID statistics? In Washington, for cases and hospitalizations, 42 to 43% of data is missing. That drops to nearly 0% for deaths and 7% for vaccinations. But obviously, if the 42% skews in any direction, making comparisons seems irresponsible. And any advice for FOIAs that can get at why so much data is missing in cases and hospitalizations? So that's a tough one. Washington is actually one of the most responsive states in the country as far as FOIA is concerned. So you're in good stead there. We've had very good success. There's a great New York Times story that came out that we helped out a little bit with by Mike Baker that looked at lessons learned in the Seattle area and how some of those lessons, if applied elsewhere, could have resulted in a far less death rate in this country. But as far as case and death information in Washington, we've been able to get medical examiner death information fairly easily, including identifiable records. That said, you have to essentially connect, that's after the fact, obviously, and hospitalization, when you FOIA for that material, there's a lag of either several weeks or several months. So the information they report out is going to have to be on their dashboard. And if there is a delay in a hospital reporting out what they're seeing to a state agency or some sort of coding issue locally, that's on their end, and the dashboard is the only place to go, really. For information on vaccination we found Washington State is reporting everything to the CDC, I think including identifiable information that includes names and full street address. So that means in theory, if there is issues with vaccinations, adverse reactions, reinfection, variant breakthrough, that should all be reported up. One piece of advice is, say, for example, like in Marion County, Oregon, across state lines, where there is a new variant, a mutation that's was found, I think, a week ago. So Marion County Public Health refuses to release information about that case. It's probably tied to a healthcare setting, they said, but they don't want to say where that was and how many people were infected. The CDC is reporting out all variant cases nationwide, but they're only doing so in one lump sum by state. They're not doing so necessarily by county. We found that if you FOIA for those counties and ask for emails with key strings, non-case sensitive key strings, like variant, B117, mutation, things like that, that can help in trying to bridge the gap between what is being publicly reported and actually what they're seeing on the ground. Not sure if that helps, but feel free to contact us offline if you have any other questions.
One other thing that, sorry, this has to do with death data. Just because there was a lot of race and ethnicity information missing from the first lot of death data in a few counties in California I was looking at. Repeated FOIAs sometimes really help because they go back and fill in those columns. So you have overlaps, you get more cases, you have more, I don't know that it'll help for 42 to 43% of data missing, but sometimes it is a function of time, and repeated FOIAs help like fill in those gaps.
That's a good point. And with Kira and I got on the phone for that Sun Times story with the director of the Illinois Department of Public Health, Dr. Ezike, and we asked her. We had heard that Illinois was only getting race and ethnicity data for 25 to a third of all vaccine recipients statewide. And so that means that even though it was required, providers, mainly Walgreens and CVS, were not filling out the forms correctly and not sending that back up to the CDC. Dr. Ezike told us, and we need to fact check this, but that number is now 90%. They sent out a siren alert, which is like an internal sort of warning system, but basically a mandate that everyone needs to collect that data. And then they also went back and reverse engineered. They made sure to connect old vaccine information to the individual patient and make sure that they connected race and ethnicity to that. So now they claim that's in the 90% realm, which is much better. So there are sort of solutions journalism sort of approaches to some of these stories, and FOIAing for that type of information would be incredibly useful. Illinois has very good public records laws, we found, interpreted very differently. One county will give you everything, and then another county will give you nothing. But it's worth trying multiple different places if you can. So I don't see any other questions in the chat. Sorry, Clarence, to jump in there, but did you have any questions that you had?
I just was wondering about, well, you mentioned that troubling word variance a couple of times here in your discussion. I was wondering if the emergence of variants on the original virus have caused any particular challenges and for you all as far as research goes, and also as we've seen for the CDC and others, trying to keep up with the changes. I imagine that while the kind of research that's being done by journalists would have a particular impact on that.
Yeah, the variants are so fast moving, doubling at a rate, 10 to 12 days in some cases with the British variant, but also the ever changing sort of literature on how damaging they are and how they can reduce the efficacy of vaccines. It's a challenge from a FOIA perspective. I will tell you, we've put in a lot of requests. New York is a difficult state for FOIA. It's actually called FOIL here. And New York City is one of the most restrictive places in the country in terms of providing public records in a timely fashion. But we found that if we go upstate and out of the city and go to the tri-state area, including New Jersey, we've had better luck. So we've been putting in requests regarding the variant. And what we're seeing is, like a lot of news reporting that's gone out about it, there's a lack of genomic sequencing of the variants nationwide, and that's due to just lack of available state lab testing or federal testing. But we've also found that it can be difficult when you have a sample of someone's COVID positive case and you're retesting that, you might use up the entire sample. And so there's not enough sample left to do a full genomic sequencing at the end of the day. And we found that with a few cases in New Jersey with healthcare workers who were tested positive for the virus breakthrough. So this was after they got the vaccine and potentially had a variant. So that's troubling. These are very small, limited cases, but ones that, New Jersey reporters, I know Michigan reporters at the Free Press are working on stories about this in prison settings. So those are worth following and trying to glean as much as you can, because that's an area where, because of privacy concerns, healthcare departments are very careful not to release any bit of information about those who contract variants. So learning as much as we can about them is useful.
Indeed. Speaking of New York, I'm sure books will be written about the undercount of nursing home deaths and political implications of COVID record keeping and reporting there. I was wondering if this is particularly, well, what kind of lessons have journalists learned from the New York experience?
So I'll mention two things. One, I think we have someone on this specific call, Anjali, who is working with a group of us over with the nonprofit newsroom, The City, on a project called Missing Them, where they catalog every death in New York City due to COVID. And there's been some good accountability coverage based off of those deaths related to nursing homes, undercounted. So, why they were undercounted, by virtue of the Cuomo administration, but also the type of care they received in those nursing home settings. It varies wildly. That should be no surprise to anyone. But one big lesson learned is that not every level of care is different from place to place. And there are, I can just say that there's a lot of coverage being planned and being worked on specific nursing home providers and facilities that have provided substandard care or are not following current guidance or guidelines, including in Cook County and Chicago. But beyond that, one good story that came out a few weeks ago was about the use of hydroxychloroquine and azithromycin on patients at a Queens state-run veterans nursing home. And that was an experimental cocktail that got emergency use authorization early on in the pandemic. Everyone knows that President Trump pushed that early on. It turns out that it wasn't terribly effective. And then, of course, hydroxychloroquine can cause heart arrhythmia and other complications in patients that have underlying conditions related to the heart. And so we found several cases of veterans and nursing home residents who later died, but unclear about the causality with that cocktail and their ultimate death. But it leads to a lot of questions. When you have nursing home settings that are just trying to provide care to their residents and are struggling with rising infection and death rates and dealing with outbreaks amongst both their patients and their staff, a lot of things happen in real time that you only find out or can investigate after the fact. And so I know that, based off the Wall Street Journal coverage and other places, there's a lot of stories to be told about those.
Indeed. Well, I don't need to tell you all that big media, particularly print media, investigative reporting has been in a virtual state of crisis because it tends to be the first area that gets cut as far as resources are concerned with newsrooms. And this is what makes your project so valuable right now, because you are providing so much information that journalists can use. I was wondering if you have any recommendations to make as far as various news media, particularly local and regional press, for approaching this mammoth topic and how to investigate it in their areas.
That's a really good question. Kira, do you want to talk about a little bit about Chicago, maybe the Sun-Times stuff, and then Caitlin, maybe you can talk about Cal Matters and sort of how those partnerships came about.
Sure, yeah. So basically, we began working on the medical examiners project in, I think, September or so, which was a project that was introduced to us by Stanford Fellows, Matt Kiefer. Led that previously and guided us on that. But basically what we learned was Cook County is a place where death records are very thorough and available. And so we use those to combine public records, do data analysis, and use that information to also do our sourcing and walk through, first of all, the first day that COVID hit Chicago, and then also look at areas that have been hard hit throughout each different wave of the pandemic. And so we pitched that around in Illinois and ended up running both of those stories with the Chicago Sun-Times. But I think the most important thing to know is I think there's a perception among some newsrooms that public records work has to be really expensive. And the pretty cool thing about the Medical Examiners Project is I think most, if not all, of the medical examiner records we've gotten have been free or very cheap. So I think it's worth considering, first of all, obviously partnerships are great, but also public records work doesn't have to be extremely expensive.
That's very encouraging. And as someone who's been a Chicago journalist, I'm based in Washington now, but first came there almost a half century ago. A lot of that record keeping that you talk about came as a result of investigative reporters trying to get information on services and how well emergency situations like this were responded to. So it's going to be very valuable. I was wondering if someone else started to say something there.
Oh, I just wanted to have Caitlin mention briefly about sort of how the Cal Matters. Cal Matters is a small, nonprofit newsroom in California that Caitlin's been working with. Those stories are also public records based, but in collaboration with, in previous instances, with other reporters there. And a good example of how to sort of take a public record story and share it with a newsroom without having to pitch some big, broad investigation, if that makes sense. Caitlin, do you want to speak to that?
Sure. So because I'm based in California, I was born here and I lived here my whole life. I know the area pretty well. And so when I started working with Derek, obviously California was an area of interest to me. And having a knowledge of the area helped in knowing which counties would be likely to be responsive and which weren't. And I was even surprised, LA County is a humongous county, and it's been one of our most responsive counties. So, even that gut instinct that I initially had that maybe I wouldn't get very much from them has proven to be completely wrong. And so even though it takes time to FOIA, there's really no harm in just sending something out and seeing what will come back. And that allowed me to take stories to Cal Matters that they hadn't been covering. They have 2 full-time health reporters. And so, there's always a chance that they're already working on something, but like you said, the resources that they have may not provide enough time for them to be focusing solely on stories based out of public records. And then while filing for more public records, I'm often just taking follow-ups, talking to sources that I used for my initial story to start on the next story, and then seeing where I can supplement with public records. So it's made the process a lot more straightforward than, like Derek said, taking a humongous pitch to a newsroom and being able to really narrow in on a very straightforward story that can have a fairly quick turnaround.
And, that's, the term du jour at the moment is quick strike or quick response investigative work, but doing 800 or 1,000 word stories on the beat and combining, public records work is, it's great to get a big document dump, but without human sourcing and without, context, it essentially is not worth running, a simple response. We need a lot more than that. And Caitlin's done a good job of combining human resources and documents and also on the ground reporting. So.
Very good. Well, you've done impressive work. You're providing a tremendous service to journalism and to public health and to public accountability. And I want to thank you all for being with us today. And I want to mention, somebody mentioned earlier about the website. I know in the chat, there are links to your website, the Documenting COVID-19 project. And as I say, it's very valuable resource and some terrific stories on there already. So I want to thank you all for that, and tell everybody in our audience, if you want to learn more about how to get a grant for investigative reporting, and indeed so much investigative reporting seems increasingly to be funded by nonprofit foundations in this age of slim resources for the traditional media. Please visit our website, www.fij.org. And I think you'll find that to be very informative as well. And also later today, everyone who registered for this webinar will receive an email with a full video of the session, I am told. So I get a chance to look at my stumbles all over again. That was just always a delight, but they're very valuable resources are linked there, and I think you'll appreciate it. So I want to say to everyone in our group here, thank you all very much. And it was very inspiring and informative for us all. Thank you, and keep up the great work.